Thank you, Twila Brase, Citizen Council for Health Freedom, and I appreciate the opportunity to come and speak. I have several points to make, and I looked at the applications, and then I've listened to the comments today, and I guess I wanted to, the first thing I want to say is to the health department. I knew about this hearing here because of an email. But looking on the health department's website, it proved impossible, even looking under Emdeon, to find this hearing. So very difficult for the public to even know how to find this hearing at all. So I just point that out, as it should be a much better job for all hearings in the future. The second thing is, I have a list of questions. What concerned me about the application and this morning is the talk about the RLS. And the fact that the RLS is not even developed. It's in a stage of development, but it's not developed. So here what we have is we have a corporation coming to be this HDI here in Minnesota, but it's really not even a part of your current business model. Your current business model, I believe, as you said, has been financial, and now it's moving into clinical information services through the RLS. And, you know, to look at an application of someone who really doesn't even have the business model is a concern for us, because we really don't even know how it's going to operate. They don't even really know how it's going to operate because it's not actually functioning at the moment. And that's a concern from our perspective, to even look at this and even know how the RLS and the consent form and everything else is going to happen. It's not even clear because it's not even set up. It's also not clear to us exactly where the data comes from. I know you were asked that several times, and it's still not clarified where all these data sources are. Not clear as well who your competitors are. Now, I look at what I heard about Minhai and CHIC this morning, and I see two organizations that are going to come together into one, and I look at the possibility that Emdeon is, and the fact that Emdeon said that you didn't need a health information organization. So I look at the possibility of all of Minnesota devolving down into one organization and no competition whatsoever. There's, you know, Minhai and CHIC were supposed to be competing, but now they're coming together. So it's a concern of ours that we actually end up with a non-competitive model of this here, and all the talk about clicks and you know, total annual amounts, and that is completely unsettled. That, you know, listening to the comments here by these gentlemen, you know, it's not at all clear how much anything is going to cost anyone. And yet this is a mandate in our state that we have interoperable electronic medical records, and no idea whatsoever of the cost of this, and especially if it comes down into a non-competitive model, a mandate with who knows how much money that will have to be spent by every practitioner, every hospital, every entity doing these transactions. And I'm wondering who decides who pays. You know, Linda had very good questions about this, and totally unclear to know who pays for which transaction. Who is the final decider on who pays, and how will that be enforced? That you do not have to pay double, that you only pay for this and no more. You know, I heard flexibility from you, but, you know, flexibility doesn't work when you come down to dollars and cents and a model. And I am wondering about the consent agreement. And I know I heard you say that you're depending on providers, and I hope that it's understood, or maybe it's not understood by the rest of the audience, but I hope that it's understood, and you probably know this, that you can grab data from everywhere. All the portals can be open, and you can grab all that data, and the only consent requirement we have in this state is for the doctor to actually see what you have pulled together. So the only consent we have regarding the RLS is that whether the doctor or the hospital has permission to look into the health information exchange and the RLS and see where all that data comes from. But we don't actually have consent for you to go grab all this data. And so it was interesting to me that you talked about if one provider sends you this form, that's the only one that's excluded. Where I believe that our state law says that a provider has to make sure it happens, not that it's an individual provider. Now, I could be wrong, and maybe this is up to interpretation, But this means that every patient would have to go to every doctor and every hospital and make sure that everyone had a consent form, and they might not even remember who all those folks are. So I believe that the law is written as a one-time, one thing. You just have to go to one provider, and it sets it out through the entire system. But I didn't hear that from you. And so, and my concern, of course, is whoever asked the question about hacking and breaches, very good question. And my concern is very much, I just read an article from someone, I think, in the federal government, because we have no idea how many breaches are happening. We have no idea. And so the fact of the matter is, to move to a system where you have all this access to data means that we move to a system where individuals are way more vulnerable, because you'll have all this data from everywhere. And so it's a vulnerability thing. And I think the consent has to be way stronger so that you don't even have access to that information to be hacked. So that's the comments that I'd like to leave you with. I think there's a lot of unanswered questions, and I think that it's concerning to us that there's a business model being talked about here that actually isn't in place, that we actually can't even see what's happening with it. So thank you very much.
Thank you. Why don't we get a couple minutes? I don't know, Rick or Nathan, if you have any response. We don't want to take too much time, obviously.
Okay. Just a couple of points I think are important to respond to. And so thank you very much for the comments. That were very helpful. As far as the RLS, it's true that our RLS is in development to be rolled out there. I do want to make a couple of, I think, important points. One, e-prescribing is a clinical solution, and we've been doing e-prescribing for 10 years. So the information that is passing back and forth is clinical information, not just financial information, and it is very important to understand the privacy and security and the importance that we take on all information, whether it's financially based or clinically based. It has information. We also, one point that I didn't make earlier that is important to make, that our clinician product that is in production and is being sold has an RLS built into it as well, and that's the way that our clinician product is able to pull information back and forth as well. So while it's not part of the exchange and is not made, will not be a part of the large circle, it is an EMR, and most EMRs have a way of pulling history of the medical or medication history together, and we do that through an RLS system. So it's not that RLS is new to us. It's just in the evolution of making medication history available. That's what's being developed right now.
Right, and just to expand upon that, it's the construct of the data. We've already been processing the data for this many years, but not putting it together and packaging it in a way which can be accessed via individual queries. So it's something we have experience in. It's just taking it into this context of being done separately, these services, e-prescribing, central lab processing of claims, administrative claims, putting together in one central database and making that available via queries. So again, if we do have experience in that, it's just in a different context with the RLS as opposed to our separate business segments doing that independently.
And related to the data sources, I thought I was clear earlier on that. Our data sources are coming from our providers, pharmacy and physicians, and they're coming from the transactions that are flowing today on the financial transactions, and that's where I was saying we're evolving from financially based information to clinically based information. Will always be a supplier of information as financial transactions flow through, but we believe that will be the starting point for us as we're rolling in this RLS service. So that's that. As far as competition, there is competition in the marketplace when it comes to medication history, and I'm comfortable saying that the competition that I'm aware of that's in the marketplace today is SureScripts. We believe, as I mentioned earlier, that there should be more competitors in the marketplace, and that's why we're entering into this marketplace. We believe, as you mentioned, Twila, that it is important to have competition in the marketplace, and to have a single competitor or a single offer of service is not in the best interest of the consumer. So we believe that entering into the marketplace will only help to allow for better services at more affordable price, and asking those important questions: who pays for the service? And to that point, as far as who does decide on the fare, ultimately the person that's paying for it decides on that. Who we market the service to, while I'm not, and our company won't control legislation that requires services or information flow. We will work with the restrictions and opportunities in the areas where we can and offer those services. And ultimately, the consumer of that information has a decision to make whether or not they're willing to pay for the information that's out there. And if we don't have a business model that anyone will pay for, that will restrict our ability to offer that service. So it really is a market-driven solution that we need to deal with. And as Tim mentioned, we've got a suite of services, and what we're looking for is, do you want all of this, or are you just interested in this one little piece? And if this one little piece is where everybody is interested, that's where we're going to be focusing our resources on, and the other components won't be available because there won't be somebody that's looking for them. So, and on the consent, I think we've covered most of the questions. I understand the concerns with that. We're very concerned with privacy and security when it comes to consent. And as we go to a more electronic world where information is passing back and forth, both financially information when it comes to your credit card and when it comes to healthcare and provider, we take it very seriously and look to both federal and state regulations as well as our own policies to make sure that we're abiding by and holding those very securely.
May I ask
Thank
a
you.
question?
Just one.
Yes. I'm wondering about the contracts are they contracts between the providers, and when it comes to sharing information with the Department of Health, are those agreements that will be written up and available to the public?
When it comes to any agreement to share information outside of a provider arrangement, you would have to have consents with those that originate that information. So if we have a provider that would like us to supply information to the Department of Public Health, we would do that under a contract from that provider.
Okay, so no contract with the Department of Health?
Not that I'm aware of.
But the Minnesota Department of Health makes a decision about who offers the certificate.
They would. I believe they offer they're the ones who grant the certificate that allows us to produce the business or to provide business.
Right. Okay. Thank you.